Good evening, everyone. Ayuhu kameyamanena dharmartha sugasadhanam Ayurvedopadesheshu videyaha paramadaraha. A warm good evening to all our delegates. Your support had made yesterday's webinar a big success. We hope the same in the future as well. I invite you towards the second day of our webinar series, Yogya 2K23, and we are moving forward with today's session. People are not born great. Their achievements and career make them great. And today, we are all blessed to be here with such a great personality, the head of our institution, our principal, our personal pride, Dr. Raghunathan Nair sir, is guiding us through today's session, Navigation through Ayurveda Proctology. May I invite Dr. Deepti ma'am, Professor, Department of Shalya Tantra, to address the gathering and invite Dr. Raghunathan sir for the session.
Thank you, Lipita. Good evening, all. Welcome you all for the second day program of Yogya 2023 webinar series. Hope you all had an informative session yesterday by Dr. Mukesh on the topic Concept of Avarna in Clinical Practice. And today, the second day session will be on the topic Navigation through Ayurveda Proctology. It's, of course, a relevant topic for the present era as Ayurvedic proctology has become very popular nowadays by its benefits and by which through the uh, quality of life of a person can be improved. And today we are really blessed to have an eminent personality in this field to speak on the topic, Dr. C. Raghunathan Nair, MS, PhD, Principal and HOD, Department of Shalya Tantra, Srinarayana Institute of Ayurvedic Studies and Research, Kollam. Sir has got a vast experience in this field over 32 years. And Sir is very popular in this field by his easy and excellent way of handling anorectal cases. And with great pleasure, I welcome Sir to speak, to enlighten us with his knowledge. And I request all the participants to utilize the session maximum. Sir, please.
Thank you, Dr. Deepti ma'am, for your kind words. And I am not having the degree MS. Instead, during my PG days, it was MD Shalya. Thereafter, I joined another course, PG diploma in radiology. Thereafter, I completed and awarded PhD from Kerala University. Thank you once again, Dr. Deepti ma'am, and I welcome all the delegates who are presenting in this webinar. So I have been asked to present a paper on Ayurveda proctology, navigation or an exploration. Next slide, sir. So we know that these are the, if we list out, there would be around 10 kind of diseases. But in our day-to-day practice in the proctology department, we used to deal with arches, bhagandara, perikartika, that is anal fissure, Buddha Brahmsha, it is rectal prolapse and rectum, Arbudha. Next. Those, see, when we come to the etiology of ashes, one is dosha kopa. We should, so in this context, it is better to read the Nidana recommended or mentioned in the Ashtanga Hridaya, Vagbhada Ashtanga Hridaya. And in it, it is said that dosha prakopa hedustu prak ukta sena sadhite agno male ati nichite punischa adi vivayataha yana samshobha vishama kadhina ulkudigasane Vasti Netra Asma Lostra Purvitala Cha Eladi Kadhana Prishasidambu Sansprasat Pratatadi Pravahana Vada Mutra Shagrit Vega Dharanat Tat Udiranat Jwara Gulma Adisara Ama Grahani Shobha Panduvihi Karshanat Vishamaphischa Dveshta Cheshtabhyu Yoshidam Punaha Ama Garbha Pravatana Garbhavritti Pratirana Idrisescha Abarer Vayu Apanaha Kupitomalam Payor Valishu Sandhete Tasu Apishnamutishu Jayante Arshamsi. So without understanding this sloga, or it is better to say, if you try to learn this sloga by heart and try to explain in terms of your experience, so you would get a clear-cut idea, not only regarding arshas. When we come to the modern medicine, they may know only the piles. They say that it is first, second, third, and degree, but it is a cluster of disease associated with arshas. Cluster in the sense it can also be a severe rectum. It can also be an overactive bladder, or it can be associated with any kinds of lower GIT issues like udavartam or arshas or pravahika, or any diseases associated with bladder, particularly mutrakrichanam, and of course bleeding per rectum. So collectively, it is termed as arshas. So one of the nidanas mentioned by Ayurveda is Vada Mutra Shagr Vega Dharana, that is suppressing urges, particularly Vadam and Mutram. Mutram and Shagat. Vada, Mutra, flatus, feces, and urine. Either it is suppressed or Tat Udiranat. Udiranat means we are taking a lot of strain. Or we can also, some people, I have a patient who is to do daily enema, that is nature cure enema for evacuation of feces. What happened? His levator muscle became loosened. It became laxed, and it descended down. So that is also that may be the reason Acharya says that Tat Udiranad also is one of the major cause for piles, particularly prolapse. So what are the nidana enlisted in short is Agnimandya, excessive sex, trauma, trauma due to a vasti netra, or due to a pressure while traveling, or if we are sitting on a rough surface. So diarrhea, indigestion, pregnancy, abortion. So what would happen? All these would create some pressure over the anal cushions. That's why Acharya says that Payor Valishu Sandatte Tasu Abhishanna Murtishu. Here it ultimately reaches Valis. Valis means there are three Valis. We know that Pravahani, Visarjani, and Samvarani. And the Pravahana karma, the flow of motion towards downwards, due to the ampulla of the rectum. In fact, that is not the space or site of piles. Now we come to the second phase, Visarjani. And that is the mid part of the anus. Probably that area is the site where piles develops. So that is the valley. So in that area, the anal cushions, there is a chance of protrusion towards downwards, which causes, eventually it leads to piles. Next slide, sir. Now there was an old concept that it was due to varicose vein. That is why some people are prescribing some medicines which are meant for varicose vein. In fact, varicose vein, the etiology of varicose vein as well as the etiology of piles is totally different. It is related to Agnimandya, whereas varicose vein in the legs are not at all related to Agnimandya. So varicose vein was also considered as one of the reasons, means rectal plexus varicosity. Now the new theory is that abnormal downward displacement of the anal cushions, causing venous dilatation located in the left lateral, right anterior, and right posterior. If we place a clock, we can see if we can understand the level of 3 o'clock, the level of 11 o'clock, and this level of 7 o'clock. If it is a mass is seen at the 3 o'clock position, it can be termed as left lateral. If it is in the 11 o'clock position, it is the right anterior. If it is in the 7 o'clock position, it is the right posterior. These are the positions normally we see while doing a proctoscopy. Then anal cushions undergo pathological changes such as abnormal venous dilatation, vascular thrombosis, that is another issue, and a degenerative process in the collagen fibers and fibroelastic tissues. And finally, distortion and rupture of the fibroelastic and subepithelial tissues. These are the causes to eventually it leads to the prolapse of or the formation of bile masses. The conclusion is nothing but new theory justifies the Ayurvedic concepts of the role of valleys in the etiopathogenesis of ulcers. The etiopathogenesis of ulcers in the old theory, which does not compromise with our theory. Our old theory, not the modern medicine old theory. Our old theory is justifies the new concept of the modern medicine theory. Next slide. So let us have a look into the picture. You can see according to the Gray's Anatomy, which is supposed to be one of the best anatomy textbook. According to Gray's Anatomy, 38 mm is the length of the anal canal. Now you can see a lower part 8 mm and a middle part another 15 mm and an upper part another 15 mm. So the middle part is highly significant. Why? Because morphologically as well as surgically, it is pain. It is an area where we feel more pain. It is highly sensitive. That area is known as the pecten area. The pecten area, which separates the upper area with a line known as the pectinate or the dentate line. So this line demarcates two zones. The above zone is it is not at all painful because which is being served by the insensitive nerves, whereas the lower part of the pectinate line is served by the pudendal nerve, which is highly sensitive. That is why any pathology in the pecten area or the level of the pectinate line is highly painful. That's why perikartiga, fissure in ano, is highly painful. An infection at this level, either due to an abscess or due to a fistula in this level, is also painful. Whereas a pile mass which arises above the pectinate line always painless. So piles are painless. That's why patient won't say that I am having piles unless it is bleeded. When there is bleeding, the patient may notice that there is bleeding. Otherwise, the mass has to come out, protruded out. That is in the later stages. When this a late 2nd degree stage or 3rd degree stage or 4th degree stage, the pile mass will protrude. Then only the patient may notice. Otherwise, the patient may notice or not complain. So next slide, sir. Now we should. These are the examination point of view: case history, inspection, palpation, rectal examination, as well as proctoscopy. So our Ayurvedic practitioners, they have a practice that they will not mind the case history. Of course, in this case, not only in this case, every case we should have a thorough history of the case. We should have a discussion with the patient regarding the history and development of the problems. So normally, a patient who comes with bile masses would have a history of bleeding per rectum. So if the bleeding per rectum is there, we should inquire what kind of bleeding, whether it is just like a splash in the pan or a blood smear in the fecal column, and followed by drop of 1 or 2, 3 or 3 or 4 drops will be bleeded in the case of fissure in ano. Whereas in the case of piles, it would be just like a splash, profuse, fresh bleeding. So by knowing the type of bleeding, we can have a clue that what would be the disease. And the kind and the amount of blood loss. In the case of piles, that would be for a long period of time, the patient might have bleeded. And eventually it leads to anemia. And sometimes when we exam the blood, we can see that the HB level would have been come to 6 or 7 or even 5. So that time that it's an acute condition, we cannot manage with drugs. It has to be replaced with the blood. So blood transfusion is necessary in such type of. In another case, now the incidence of rectal carcinoma is it is a common due to the new way of life and way of habit, the habit of food that we consume, a high amount of red meat and high amount of drinks and the parota, like fine flour products like parota or something else. And we are not having not taking too much of high fiber diet and lack of adequate water intake. So because of this issue, there are chances of developing cancer, and the incidence of rectal cancer has been increasing a lot now. So in such cases, there is a chance the bleeding or the discharge would be just like meat wash or fish wash appearance of bleeding. So when that time we should doubt, is there any chance of CA rectum or not? And that is must. Then we come to the inspection, a meaningful inspection at the end. So the patient has to be placed in a lithotomy position so as to visualize the area. Sometimes the patient may be unable to lie in that position due to aesthetic reasons or due to pain. So we can place them in the left lateral position. But as far as a practitioner is concerned, lithotomy position is most advisable. And inspection, we should see the perianal area. What would be the color? Is there any color changes are there, or any swellings are there, or any sometimes due to the wet environment of this area, there are chances of developing fungus. Eventually, it leads to itching and fungus infections, which is known as pruritus ani. And sometimes there are, if it is an old fistula, there will be chances of ulcers in the form of external opening. Sometimes, if there are external openings, we should know the numbers and the site of the external opening and the distance of the external opening from the anus. This has to be noted. So there are many things has to be examined during the inspection, case history, etc. And now we come to the palpation. Palpation, we should see, suppose a swelling is there, whether it is tender or not. And suppose we have seen an external opening, and trace the external opening with index with our finger, so that we can trace it out, the course of the track, whether it is straight track or taking a curve, whether the track is taking a curve or it moves or it courses the track a very straight or curve. That has to be taken by means of this palpation. And then we come to the rectal examination. Rectal examination, the rule is we can also stretch a little and see that whether any fissure is there. Even after the application of certain silocaine, local anesthetic jelly or local anesthetic spray, sometimes there would be spasm in the case of acute anal fissure. In such, if there is spasm, should not try for PR examinations. We should manage them to reduce the spasm by means of some analgesics or some soft stool softeners or any anuloma drugs has to be given to release the spasm. So thereafter, as and when the spasm is relieved, we can try for PR examinations. In other cases, except the acute anal fissure, we should do the rectal examination or the digital examination. The indexed finger has to be inserted and has to see the texture of the mucosa, whether it is soft or hard. Normally, the mucosa would be soft. If there is any CA, there are chances of infiltration of the mucosa, and it would become, we would feel a hard mass. And in the case of internal opening of a tract, the fistulous tract, the internal opening would be palpated just like a pimple. If we palpate a pimple over our face, similar kinds of information can be gathered from the PR examination. And we should also see in the case of male, the roof of the anal canal, we can feel the swelling of the prostate. You know, after 50 years, there are chances of developing senility, senile as prostate hyperplasia. That can be also palpated, whether it is soft or hard, and which lobe is so hard and which lobe is soft. So these are the informations can be gathered from the digital examination or per rectal examination. Now we come to the proctoscopy. Proctoscopy is a Arsho Yandra in our Ayurveda. It is a Arsho Yandra. It is a Nadi Yandra, a tubular instrument. So it should be sterile and by means of sufficient light and sufficient lubrication that has to be inserted. And we can directly visualize the whole anal canal as well as the lower 1/3 of the rectum and see the color of the anal mucosa. Normally it is pale pink. Apart from pale pink, in the case of piles, it would be red in color. And see any discharge. And what are the numbers of piles? What is the size of the pile masses? And what are the sides of the pile masses? Is there any bleeding surface in the pile masses? So these are the so there are a lot of information you can gather from the proctoscope. So this has to be this inspection, this examination is very, very important. Next slide, sir. So you can see the pile masses. This is the left posterior, and this is the right posterior, and this is the left lateral. Because of the dragging, it has been come down. You can see the pile masses. It is plum colored or brick red colored, the internal part, and the cutaneous part has been dragged. Next slide, sir. So to be noted in the case of piles, the age range would be in the range of 30 to 65. And the type of bleeding which we have discussed, anemia has been discussed. And the kind of discharge, whether it is mucoid or pus, pruritus, etc., has to be noted. Proctoscopy, okay, doubtful. So in the case of doubt, we sometimes if we have any doubt, should advise colonoscopy. Now it is a common practice to inquire any issues in the colon. So moreover, we can also have a biopsy from the colon for histopathological study. Now, the incidence of CA, not only CA, but inflammatory bowel diseases like Crohn's disease as well as ulcerative colitis is also common. So, a long history of Crohn's disease, a long history of ulcerative colitis, there are chances of cellular or molecular changes, which eventually leads to CA. So, to rule out, it is beneficial to have a colonoscopy along with a histopathological study. Next slide, sir. So causes for bleeding per rectum, one is piles, another is fissure in ano, ulcerative colitis, polyps, amoebic colitis, fistula in ano, carcinoma rectum, carcinoma colon, diverticulitis, and intersusception. Next slide, sir. Now, we can see the arrow has been pointed. It is not a piles, but it is a warts. It is a viral infection that can be easily managed with the karma. Next slide, sir. Next. So this is, you can see there is no discharge. Normally, in the case of Vada or Kapha or Vada Kapha nature, it would be dry, it would be Shushka in nature. If there is any bleeding or any discharge, then it can be bleeding, then it can be Pitta or Rekta associated. So it is a 3rd degree pile mass. Next slide. Now you can see a prolapsed piles. The whole mass is prolapsed out, and which is known as fourth degree. It cannot be reduced. And the other one is triangulated. If the pile mass is gripped outside, and there is a chance of twisting, so the venous return will be blocked, and it would become strangulated. Next slide, sir. This is another perianal hematoma. It is not, in fact, it is not abscess. It is due to capillary breakage in the subcutaneous area of the anal verge. It will be much tender. If you palpate, it will be tender and painful. This can be very easily managed with Jaluga vagina. In modern surgery, they used to excise the mass, and since it is a zone of infection of the E. coli from the feces, so there are chances to avoid such kinds of infection. It is better to apply Jaluga, and immediate relief, sudden relief would be, you would get sudden relief. Perianal hematomas. This would happen due to a long journey. There are a lot of patients who are having the habit of using two-wheeler, and also long journey. Suppose persons who are travel from the Kannur to Trivandrum or such long places, these kinds of inflammation due to the breakage of. That's why in our Nidana it is said that Yana Samshobha Vishama Katina Ulkudigasana Vasti Netra Asma Lostra Urvitala. Even due to the heart or the what you call the undergarments, if we are so hard or it is very tight, in such cases it is a chance of developing the breakage of this subcutaneous capillary, and eventually leads to a hematoma. Next slide, sir. Anal carcinoma. 80% of the carcinomas are in squamous cell carcinoma, a cauliflower-like appearance. And you can see the other one. You can see the margin. It is, margin is it is hard. It is indurated. Next slide, sir. Next. So the treatment is in three ways we can manage. One is preventive, and therapeutic, and medical. And preventive, we can manage with fiber-rich food and lot of liquids, plenty of liquids and laxatives. And therapeutic, there are medical, parasurgical, and surgical. And the concept of Ayurveda is Deepana and Anulomana. That is the main concept of that management of piles. Of course, in modern medicine also, they are advising carbonatives and laxatives. But the concept in our Ayurveda is more relevant. That is Deepana and Anulomana. Next. Now we come to certain medications. For example, there are n number of medications in the form of Kashaya, Arishta, pills or capsules, Lehya, Thaila or Grita, Churna, etc. We can select according to the situations. We can have Chirivilladi is one of the best drug. It is the most effective drug. And Gandharva Gastadi is also almost all the except one or two. Except I think Gandharva, Chirivilladi, the ingredients of Chirivilladi Kashaya is there with Gandharva Gastadi as well. And Dusparshagadi, Mahatiktaga. Mahatiktaga is given when the patient is having burning sensation or bleeding. In Paitiga associated conditions, Mahatiktaga can be given. And Arishta, Abhyarishta, Dusparsagarishta, Ashogarishta, Kutajarishta, Lohasava. This Ashogarishta, Kutajarishta is mainly indicated in bleeding piles. And in cases, patients who are having a lot of blood and eventually leads to, if we are suspecting that there is a chance of anemia, you can also mix with Lohasava. And Kankainavati. Kankainavati is Sughabedi of the Kottakkal Ayurveda Shala. Misraga Sneha capsules are available now. And Sarangote Nai is prepared by SKM pharmacy Salem, it is nothing but Sarangotai Tamil terminology. It is Bhallataka. Bhallataka, that ghee can be given suspected CA rectum as well as Vada Kafatika. Vada Kafatika assist the Sarangotai is also very effective. And when we come to Lehya, Suranadi Lehya, Bakushala Gula, Kalyanaga Lehya, Kutajatogadi Lehya, Manipadra Gulam, Trivurt Lehyas are available. And this Kutajatogadi is particularly meant for bleeding period. When we are having, when the patient is doubting, when we want to deal with the more amount of blood loss, Kutajatogadi Lehya is one of the best. And Pipalyadi Anuvasana Tailam, Katapa Tailam, Unduru Tailam, Mahatiktaka Ghadam, Murivanna, Thanvandara Tailam, Sadatauda Ghadam. These medicines should select according to the appropriate conditions. And Pipalyadi Tailam, when it is associated with complaints like Udavarta or Mutra Krichra, you can instill 5 to 10 ml of this medicine can be instilled, or you can also advise as a Snehavasti. Then Katapathaila is also found to be effective in prolapsed rectum. Unduru Thailam is available with SNA Ayurveda pharmacy, and this Katapathaila is available with the Srinarayana Ayurveda pharmacy. As well as Ashoka pharmacy of Kannur, they are preparing this Katapathaila. That is also found to be very effective, and they are using in our theatre for prolapsed rectum. And Mahatiktaka is also good for both for internally as well as per anally or internally. This is meant for bleeding and for burning sensation. When there are in case of anal fissure, burning sensation would be more. You can apply locally. Mahatiktaka ointment are available now. Mahatiktaka ointment of the cortical Ayurveda is found to be effective to apply locally, and you can also advise this drug in the form of ghee preparation orally. Muruvanna according to its indications. Gudatalam Vingunno Arsasinam means it is an anti-inflammatory and analgesic action. It is also recommended for burning sensation since it contains Palandu, the small union along with the Shadavari. It is very effective in managing burning sensation always found with anorectal issues. Then Dhanvandara Mejupaga. Dhanvandara Mejupaga is advised to instill for laxity of this levator ani muscle found in prolapsed, partial prolapse of the rectal mucosa. And Shadatauda Grada is also very effective in burning sensation, particularly in fissure in ano, pericardica. And Churna, Hingu Vachadi Churna, and it is particularly mentioned in I think in Ashes, it is mentioned in Gulma, but it is mentioned also in Ashes with Takra. When there is proctitis along with fissure. So fissure, there are chances of developing Gudashwaidu as well as Gudakandu and Gudashula. So along with other medication, Hinkuvajati with Takra is found very effective. And for Pushyanaga Churna, it is those who are having bleeding. Only for bleeding per rectum, Pushyanaga is also found to be very effective. And Hudapugadi Churna is good for Vata catharsis. And Triphala is okay, but in certain patients, Triphala is not sufficient for smooth motion. So there we will have to add this Brihat Triphala Churna, which is available only with the Vaidreknam Aushadashala. That is, I think, a Sukha Virejana drug for patients having constipation. Pramala Phasma is also very effective in bleeding. Suppose some the mucosal bleeding are found to have some ulcers. So we can apply a paste with honey on that surface, and also we can consume. And now cortical Ayurveda have these capsule forms. So it is very easy to consume. And Kalyanakashara is not meant for piles, but some cases there are chances of Udavarta and Mutra Kricha. Yesterday, Dr. Mukesh sir said, Samana Vrda Apana, Anyonya Avrana, in some cases where Samana and Apana are involved. So there would be Mutra Krichra, there would be Arshas, there would be Udgara, Bakulya, Purisha, Bandha, Triti, Akshamata, Andhra Vigujanani, Atopam, Atmanam, Avakta Shakti. In such cases, these are the symptoms associated with sometimes with the piles. So in that cases, Kalyan Chara, along with the Charngeya, the Grida or Sukumara Grida or plain ghee can be given. Next slide, sir. So now we come to the parasurgical techniques are recommended for managing pile masses. It is an old therapy known as sclerotherapy. Now we all, these sclerosing agents are easily available for the management of varicose vein in the legs. Here we can, the phenols are available and virgin coconut oil are available, 95 ml of virgin coconut and add 5 ml of 5% phenol and stir well and take 3 to 5 ml and you can inject submucosal pedicle of the pile masses just above the dentate line. It is very effective. It is very effective. The syringe is known as Gabriel syringe. So you can see a long needle and at its tip another again at the needle at the end of the needle again fine tip is there. Through that you can inject at the pedicle. Next slide, sir. Jaluka Vadrana, it is mainly meant for thrombosed piles. When the piles are thrombosed due to the clotted blood in a capillary bleed, that is very, very effective. But in otherwise, it is not much effective in normal arches. Jaluka Vadrana is not much effective, but it is highly effective in these thrombosed piles. Hematoma or thrombosed piles. Next slide, sir. And here I had a patient, an old patient, very old patient. He's a carpenter. He's a carpenter, and his pulse rate is always 40. So it is very difficult to manage with local anesthesia or something like that. So without any anesthesia, and in this case, not only piles, little prolapse of the partial rectal also there. I managed with Chara application. The patient is now it is happy. Next slide, sir. And this is the Chara application subsequent visit. Next slide, sir. The same patient. And cauterization progresses. You see, it is the as and when the cauterization, the area would become blackened. Okay, next slide. This is another patient. A long history of strong and forceful strain at stool caused bulging and managed with the Jaluga and oral medication. So I initially I thought that it is a 4th degree pile mass, but it was not a 4th degree pile mass. It was due to forceful strain. The patient used to force a lot, and all of a sudden it developed. And he had a lot of problems with his digestion, and he used to have strain. So with the Jaluga Vadrana, I could manage. Next slide, sir. The another is rubber band ligation. This is also a common practice, and our in our Srinarayana College we are practicing this one. Dr. Arun Mohan, you are in the bathroom. For the second degree piles, it causes an ischemic necrosis, and piles falls off. One sitting, 2 piles, repeat 3 weeks. Band placing 2 centimeters above the dentate line. Here it is a rubber band that is being put above the dentate line or above the pedicle of the pile masses. 2 bands should be used to take care of the breakage. Tissue sloughs off in 1 to 2 weeks, having an ulcer which heals by scarring. Equipment is inexpensive, simple to perform, no anesthesia, and in the OP can be managed. It stops bleeding and tackles and prolapsing anal cushions, contraindicated in fissure, fistula, and proctitis. Complications, if applied low into skin, causes severe pain, discomfort, secondary hemorrhage, and ulceration. So it should never care that it should never be in the skin area, the cutaneous area. So it should be above the dentate line. Otherwise, it would be severe painful. Next. Next, sir, next. And this is the instrument. You can see this is the Barron's band instrument, and this is the suction apparatus. So here at the tip, you can see a conical part, and through this part, the rubber band is pushed towards its base, and this part will be removed. And there would be a hollow structure, and this hollow structure would be pressed over the pile masses, and the base would be connected with the suction, and then the suction pressure, that would be sucked. The pile mass will be sucked through this hollow structure, and as and when the full pile mass is sucked into the hollow structure, then we can shoot by using this device, and the two rubber band can be placed over the pile masses. Next, sir. The IRC, it is infrared coagulation. Here heat is applied over pile mass. It causes blood coagulation within the hemorrhoid itself, which causes the hemorrhoid to shrink or slough off. Source is infrared rays of 14-volt are transmitted, applied at the base of the pedicle above the dentate line. There is a timer. I will show in the next picture. There is a timer for to set that can be set for 2 seconds, and when we push the button, that heat will be released at a depth of 2 mm to 8 mm. And the time taken will be 2 to 5 minutes. First, second, and third degree piles can be treated. Long-term results are not good. Equipment is expensive. Next. And this is the instrument. And 20 years, it was only 1 lakh, and thereafter it came down to 65,000. Now it became 2 lakhs. But since it is being imported from Germany, that's why it is costly. And this is a bulb. Here the infrared is generated, and there is a long glass tube, and at its end there is a tungsten end. This tungsten end is placed over the pile masses, and we can set the time so that the heat would be at 100 degree. So it is just like Agni Karma. So we can in a pile mass we can apply 3 to 4 spots. So the whole area will be cauterized. This is also found to be very effective. Next slide, sir. Other methods are cryosurgery, nitrous oxide at minus 98 degree, or liquid nitrogen minus 196 degree, using cryopro. Now it is being outdated, nobody is using, but in certain eye surgery, the cryo application has been is using. The laser therapy for 3rd degree pile mass, beam of light interacts with the tissue and used to cut, coagulate, or ablate the tissue. That is laser therapy. Now it is now it is in practice. And another is Doppler guided hemorrhoidal artery ligation. Doppler guided hemorrhoidal artery ligation. That's known as DGHAL. So by means of a Doppler ultrasound, the hemorrhoidal artery will be identified and will be ligated. Here there is no need of any anesthesia. There is no pain and no blood loss. Next slide, sir. So the latest one is stapled hemorrhoidopexy. It's a minimally invasive procedure for hemorrhoids, MIPH. So circumferential excision of the mucosa and submucosa 4 centimeter above the dentate line using circular hemorrhoidal stapler passed per annum. It is less painful, less blood loss, faster recovery, short hospital stay, and highly effective. It is done only for prolapsed piles, but the cost is more. The cost is more. Next slide. And this is the instrument for stapler hemorrhoidopexy. Next slide, sir. This is the hemorrhoidectomy, Milligan and Morgan method, which is known as, there are two kinds of methods. One is open method and another is closed method. Here we can, the pile masses is, dissected. Means it is dragged by means of forceps, and the cutaneous component of the pile mass is also dragged. You can see clearly the pile masses, and a V-shaped cut will be made over the skin up to the mucocutaneous junction, and the mucous part, that is the pedicle, is transfixed, and the remaining part would be excised. That is the practice of surgery being done. Okay, next. Then now we are practicing Shara application. That is recommended for second and third degree pile masses. Shara means it should be Tikshna Shara. We have Mridu, Madhyama, and Tikshna. Here we need Shara, which is made out of even Kalka. With Kalka, Shara paste is applied over the mass one after the other. No need of any local anesthesia. But when we want to drag the skin, that area has to be anesthetized. But when cutaneous component present, there is local anesthesia is required. Otherwise, no need. After 2 minutes of application, wash and with the distilled water followed by, that area has to be neutralized with the lemon juice. Instill Murivana to avoid any burning sensation. Lime juice orally to avoid alkalosis. Next slide, sir. So you can see the three pictures before and during and after. You can see the change of color of the pile mass. It has been cauterized and eventually leads to necrosis and finally peeled off. And I think this is one of the best method of management of piles, because there is no question of inner recurrence, there is no pain, there is no bleeding. Next slide. Then come to Sharasutra ligation under anesthesia. Now the forefinger dilatation has to be done. As if the previous slide, the molecular method of close method of surgery, here also we will make a V-shaped incision at the mucocutaneous junction. And first it will be transfixed with a number 2 cotton thread or number 20 barber's thread. Barber's thread is highly costly. Then thereafter it was followed by the Sarasutra tied circumferentially and the mass is excised. This is the practice in Ayurveda colleges. Of course, this also under the Shara application. Next slide, sir. Now we come to the next one, anal fissure. Anal fissure is also known as Harikartika or Buddha Vidara. It's an ulcer in the longitudinal axis of the lower anal canal from anal burst to dentate line. We have seen the dentate or the pectinate line in the previous picture. So the ulcer would develop only in this short area, but it is in the sensitive area. That's why it is highly painful. It won't develop above the level of the pectin or dentate line. So it is a short linear ulcer. So midline posteriorly common. So it can it may not develop anywhere, but it may develop most often in the midline posteriorly, because due to the curvature of the sacrum and rectum. Hard fecal matter while passing down causes a tear posteriorly. That is the chances of developing this anal fissure in the posterior midline. And of course, it also has been observed in anterior midline, particularly women in their delivery time. there are chances of developing an ulcer in the anterior midline as well. Next slide. You can see a canal-shaped ulcer. It is a chronic ulcer. Why? Because there is a sentinel piles. You can see the pile masses. This is the sentinel piles, which is developing after the formation of this ulcer. It is known as a skin tag, which can also be considered as an external pile masses. And this ulcer, it develops only up to the level of the pectinate or dentate line. Next slide, sir. In acute anal fissure, there are two kinds, acute and chronic. In acute, severe pain, there would be severe pain and constipation. Of course, there is no constipation, but the patient is due to severe pain. I had earlier said due to the spasm, the involuntary internal sphincter muscle won't allow to move down the advanced fecal column. So, though there is no constipation, the patient cannot pass feces unless this spasm is relieved. As and when the spasm is relieved, naturally there is the feces will be moved. So severe spasm without inflammation. Proctoscopy not advised in acute fissure, because due to the spasm and pain, proctoscopy is not at all recommended. In chronic anal fissure, we have seen the last picture. There is a sentinel piles. It is considered as an external pile, which is always inflamed, indurated margin with the scar tissue. And in some cases, this fissure would infect and cause an abscess. Eventually, it leads to an anal fistula. So when we ignore anal fissure for a long time, there are likely to develop an inflammation along with an abscess, and leads to a small fistula. In Ayurveda, we say Raju Bhagandara. Raju Bhagandara is a straight track. That straight track is normally followed after an infection in the chronic anal fissure. And proximally hypertrophied anal papilla is observed. A repeated infection, fibrosis, abscess, and fistula formation. Chronic is less painful than acute. Next slide, sir. In that, adequate fluid intake has to take 6 to 8 glasses of fluids per day, and should take a fiber-rich diet. Now we have polished rice we get, and polished products from wheat we used to have, and that is a problem. So rices or wheat having full bran is recommended. Vegetables, whether it is raw vegetables or steamed vegetables, are recommended. Fruits, one of the problem with the fruits is that patients are all diabetic, so that has to be minimized, or we can advise fruits with minimum glycemic index. Such fruits can be recommended. And bulk forming agents like bran. Bran means rice bran or wheat bran. Local anesthetic agents. Local anesthetic agents is sometimes necessary because of the severe spasm and pain. The patient may not unable to pass motion. So silocaine jelly or spray can be applied. Anal dilatation. As and when the spasm is relieved, we can dilate the anus so that the motion can, the advanced fecal column can come down. Avagaha Swedam, sits back. It is recommended with in Triphala Kashaya plus added with a small pinch of salt. That is good. Because since it is little hot, not too hot and not too cold, it has to be warm as the temperature of the patient's own urine. What would be the temperature of urine? And that temperature has to be given, has to be advised to sit. And under anesthesia, stretching sphincters, fissurectomy, sphincterotomy, excision of the sentinel piles, and biopsy to rule out any CA and tuberculosis. So here that is another. Normally, this can be managed with our dilatation, but in certain cases it is very difficult. So we will have to stretch the sphincters. That has to be done only under anesthesia, local anesthesia, or we can spray. The local anesthetics are available in spray form or in jelly form or ointment form that can be applied, and wait for some time, and then we can stretch. Fissurectomy, that is, personally, I don't recommend fissurectomy because we are removing the fissure and creating a fissure. Our medicines having Lekhana properties can be applied, even massaged after the local anesthesia spray or application of silocaine jelly, and you can have a small gentle massage with medicines having Lekhana, so that there is no need of any fissurectomy. Sphincterotomy, lateral sphincterotomy can be done in case of severe spasm. A small incision has to be done, and should access the sphincter through the opening, and can cut it. And excision of the sentinel piles and biopsy. Next slide, sir. So here we should advise the patient for using the anal dilator. It is available in rubber, that should be sterile and that should be lubricated. You can put in your index finger, and after applying sufficient amount of silocaine jelly at the tip, we can insert the anus and keep it for 2 to 3 or 5 minutes, so that the sphincter would be dilated and the patient would be comfortable with this. So the patient himself can be done this dilation. Next slide, sir. So after dilation with silocaine, we can keep this Muruvanna Varti dilation for a day. If it is there for 1 day or some hours, sufficient amount of relief. Since it is anti-inflammatory and analgesic, but it cannot be easily pushed into, and after dilating the anal sphincters, we can keep inside, and the patient will get a sufficient relief. Muruvanna Varti. Next slide, sir. And now we come to anorectal abscesses. So when we see the percentage of infection, Escherichia coli, that is E. coli, comes to 60%. That is the villain, because our fecal matter is full of E. coli, and which, if it gets an entry point in the anorectal zone, that pathogen would invade and it would get an entry that would eventually lead to an abscess. Remaining streptococcus or bacteroids or be protease or staphylococcus, 40%, but the major cause is E. coli. So we have seen a picture in the beginning that there are some crypts in the anal canal, and these crypts, there are a lot of anal glands are there. The ducts of some anal glands are there. The anal glands are in the the anal glands are there. The ducts of the anal glands are ends blindly in the intersphincteric space of the anal canal. And at the anal canal, we have two kinds of sphincters, the external sphincters and the internal sphincters. And between these two sphincters, there is a potential space known as the intersphincteric space, where this the ducts of these glands, the crypto glands, are blindly ends. So as and when the E. coli or any pathogen, if it get a chance to invade through the crypts, and eventually leads to an abscess in the intersphincteric space. This is a typical site of perianal abscess. And this anorectal abscesses are common in diabetic patients as well as immunosuppressed. Immunosuppressed means even tuberculosis patients, it is more common. But now tuberculosis is not a common disease now, but it is diabetes is a common. So it is the incidence of anorectal abscess are found more common now. And other causes of anorectal abscess are injury to anorectum, cutaneous infections, any boil in the perianal region, some blood-borne infections, just like our septic arthritis, blood-borne infection is there. Similarly, similar infections can be developed. And a fissure in ano, the infection can be developed through the open, the linear ulcer, and perianal hematoma, post-anorectal surgery, Crohn's disease, tuberculosis. These are the other causes to develop anorectal abscesses. Next slide, sir. So I have mentioned about the valves. These are the valves which are, and this is the level of the pectinate line or the dentate line, and above there are the columns of Morgagni. It is known as the columns of Morgagni or anal valves, which are full of anal. These are also known as crypt, and it is full of glands. That is why it is known as cryptogland. So the cryptoglands are infected. That is the main source of or main cause of anal fistulas. The cryptoglands are infected. The glands can be infected if it is get a small microscopic lesion. It can be due to a hard fecal matter. It can be due to a trauma. If you travel a lot on a bicycle, on a two-wheeler, or you travel in a train for a long time, or in a car for a long time, or what are the causes we have discussed in the beginning? The nidana of arches, all the nidanas of arches also can be leads to a fistula. Arsho nidana pithideir aberration nishevitaihi. That is mentioned in our Bhagandara nidana. So the crypts, the infection or the E. coli or any pathogen, if it get a chance to invade due to any microscopic lesion at this level, and this is the external sphincter and this is the internal sphincter, and the ducts of these glands are blindly end at this place, so an abscess would develop here. An abscess would develop here, and it eventually leads to separation and burst outside. And we said there is an external opening here, and it goes there and comes to here. And this would be the course of the track. So that's why a fistula never develops on a fine morning. There should be an episode of recurrent episode of infection. There should be an recurrent episode of anorectal abscess. An anorectal abscess would develop in a fine morning, whereas a fistula never develops in a fine morning. So this is the source of infection. Here the infection, and finally it settle here and develop an abscess, a Bhagandara Pidaga. We say Bhagandara Pidaga in between the potential space in between this internal and external sphincters. And this, from this side, it can goes to up in the supralevator area, or it can do the extra sphincter, or it can downs to the low anal fistula. Normally, low anal fistulas are more common. Next slide. So classification, perianal fistulas. Perianal fistulas are 60%, ischiorectal 30%. The remaining submucous, pelvirectal, and fissure abscess remaining only 5. So in our Ayurveda, the concept of or the description of this Bhagandara Pidaga as well as the management of Bhagandara is extensively described. In no science, these kinds of types of incision has been mentioned. In modern surgeon, they used to say cruciate incision, incision in the size of a small cross. A cross incision is recommended. Whereas depends upon the size. Sometimes it can be a Langala incision, Arthalangala incision, Chandrartha incision, a lunar type. So that is how the never sometimes, you know, in ischiorectal abscess, okay, it would be just like a spherical type and the cruciate incision is sufficient. Whereas in other cases, it may not be sufficient. We need according to the size of the or the shape of the extent of the abscess. So there we need a Langala inspection or Langala types of incision has to be done. Next slide, sir. So the cryptoglandular infection, by now we have discussed 90% of the cause of the fistula in ano is due to cryptoglandular infection. Non-cryptoglandular are 10%. That is probably due to TB or HIV or any venereal diseases or immunosuppressant causes. In that cases, the non-cryptoglandular infections are only a chance, but it is a highly negligible amount. A tract lined by granulation tissue connects perianal skin superficially to anal canal, anorectum or rectum deeply. History of recurrent episode of anal infection and abscess. So the fistula can be either high anal, that is above anorectal ring, or it can be low anal, that is below anorectal ring. So low anal fistulas in our Kerala this area, low anal, that is below anorectal rings, fistulas are more common. And some simple fistula, there are two types of fistula, simple and complex. And simple fistula without extension and complex fistula with extension. Extension means there will be multiple tracts, and the tracts would have leads to sometimes be, above the level of the levator ana muscle, supraelevator fistula, extrasphincteric fistula. Supraelevator fistula and extrasphincteric fistula are highly difficult to manage, which are complex in nature. But we used to deal with such kinds of fistula with our Shara Sutra. Next slide, sir. This is a demonstration of a low anal fistula. The external opening you can see in the anterior side. A probe has been inserted to only just for demonstration. Now we can see that track is straight, not curved. Why? Because the external opening is just above the anal canal, that is in the anterior side. There is a rule known as Goodsall's rule, which says that any external opening in the case of an anal fistula, if it is in the anterior side within 1.5 inch limit, that track would be straight. Whereas if it is in the lower half, that may take a curve, just like in the size of a horseshoe, and finally it leads to the posterior midline. Sometimes the the external opening will be at 7 or 8 or 9 or 3. Sometimes it is far away, but the internal opening would be in the posterior midline, that is 6 o'clock position. Now this is the rule. Next slide. So here also we should have an inspection that we had discussed, palpation had discussed, PR examination had discussed, proctoscopy had discussed, and here probing. Probing, I have just discussed about the Goodsall's rule. Probing means by means of a malleable, means copper probe is better, or you can also have a silver probe. And the tip should be not, it should be blunt. It should not be fine, or it should be sharp. It should be blunt. So a blunt tipped copper or silver probe should be moved from the external opening. And at that same time, we should keep our left or our index finger in the anus to trace it and to take it out. So this role, if it is in the anterior half, I discussed. And fistulogram we can use with the CT, or you can also have with the X-ray, or it can be with the MRI, or you can also with ultrasound. But normally now it is a common practice is with the MR, that is magnetic resonance fistulogram. That is more common. And with this fistulogram, we can see that the extent of the track and the course of the track and the number of tracks, whether it is external extra sphincteric or suprasphincteric, whether it is simple or complex, such kinds of information can be gathered from MR fistulogram. Dye test that we used to do in our theater, dye test we used to take a little betadine solution and hydrogen peroxide mixture. That would be injected externally, external opening in a forcefully, while keeping a proctoscope internally, and we can test whether dye is coming through the anus or not. A very simple and safe test, dye test. No other dyes are available, but no need in our theater. These hydrogen peroxide and this betadine solution is quite enough. And blood test. It is mandatory because we deal with the blood. There are a number of blood-borne infections, and it is mandatory as well to rule out any HIV, HBs, AG, that is hepatitis B and C. Any venereal diseases has to be ruled out, and moreover now the incidence of diabetes is too much, and the blood fasting as well as prostaglandin along with glycosylated hemoglobin also has to be done. And in the case of a long history of diabetes, his creatinine level also has to be seen whether it is high or not. And advise colonoscopy when ulcerative colitis or any inflammatory bowel disease are suspected. Next slide, sir. And this is one of the fistulogram with X-ray showing the track. A radio-opaque dye is injected through the external opening. So at the same time, the X-ray is taken, but here the X-ray technician has to be along with the patient. There are chances by using a lead apron, by wearing a lead apron. Otherwise, that is why they are reluctant. They are very reluctant to take this fistulogram. Why? Because there are chances of primary radiation to the investigator as well. Next slide, sir. And the other running practice in modern surgery is apart from fistulotomy. Fistulotomy is the opening of the tract by means of surgery, and another one is fibrin glue. It is a mixture of plasma fibrinogen and thrombin that will be filled in the tract, and the internal opening will be closed. So here the concept is all this fibrin glue, whether it is fibrin glue or lift or waft, the concept is same, to close the internal opening so that the infection, means the fecal matter containing a lot of E. coli, the transmission or the pass of this fecal matter is prevented through the tract by closing the internal opening. So next is lift. Lift is ligation of the intersphincteric fistula tract. Ligation of intersphincteric fistula tract. Here a transverse incision is at the intersphincteric space will be made. And we should approach the internal opening through that incision, or through that space should reach at the level of the internal opening, and the internal opening is ligated, and the remaining part is curated. But even after these kinds of lift procedure and waft procedure, there are number of cases, recurring cases has been reported. A number of cases has been reported. And in Trivandrum, there is one hospital, Lord's Hospital. They used to do all these kinds of surgery, and which eventually leads to recurrence. Waft is video-assisted anal fistula treatment. Here, a fine specialized endoscopy that will be inserted through the external opening towards the fistulous tract, and continuous irrigation with the normal saline to make the area more sterile and clean. And thereafter, the tract will be curated. And finally, the internal opening is ligated. The same principle of lift and fiber and glue. The concept is to close the internal opening so as to avoid any fecal contamination through the internal opening towards the remaining tract. In that way, the remaining tract will be closed. But I don't know. It is recurring a lot. Next slide. Pilonidal sinus. Pilonidal sinus can be managed either with the Shara Sutra or after excising the tract, Shara applied. In both way, it is managed. Anyway, the tract has to be explored either with the Shara Sutra ligation, or the tract can be laid open and Shara applied so as to cauterize the tract. Next. Here a pilonidal sinus Shara Sutra in situ. In situ means in position. A clean tract with no infection. Next slide. Mr. X with the high type 2 diabetes and hypertension, a complex supralevator fistula. Supralevator fistula is highly difficult to manage because the tract extends beyond the level of levator ani muscle. It is not a supralevator fistula. And in modern surgery, there is no option at all. They do not do surgery. They do some palliative approach, because the extensive removal of the tract along with the neighboring tissues eventually leads to incontinence, and it would never heal. So here we have little chances. It is difficult, but has to be managed very carefully. Complex supralevator fistula with the 3 external opening as demonstrated. I have demonstrated with the 3 needles. Next slide. See here, my technique was, so there would be number of tracks and number of external opening, but all the openings would have some tracks, and these tracks eventually leads to in one opening internally. The prominent one, or which have developed the first track, first external opening, would be applied with the Shara Sutra, and it would be replaced every 7th day till it cut through. Cut through means the final cutting of the track, and the other track would be healed. And this was one of the cases where I could manage with the complete closure of the fistula. But now I am watching whether it is recurring or not. So far, it is not yet recovered. No, record. Next slide, sir. Mr. Y is another patient who is from Pathanamthitta. Hidradenitis suppurativa, we can say it is Kaksha. He is uncontrolled diabetes. He is on insulin. He is at axilla due to blocked hair follicle and set gland infection, and an extensive area has been infected and fibrosed, and with multiple, there is no tract, but the whole area is full of a sac-like infection. It was just like a sac. The whole area is fibrosed. So under local anesthesia, we applied a little part is cauterized and remaining part is managed with the Shara Sutra. So the Shara Sutra alone it would take a lot of time, long duration of treatment would be needed. So what would happen? So the patient may not be happy. So we cut a little by little in our sitting with the cautery, and thereafter we apply the Shara Sutra. Next slide. Here I am using the cautery. 60% with the cautery and 40% with the Shara Sutra. Next slide. The same patient in his buttock area, in anal area, the whole area is infected with this hydradenitis suppurativa, and hardly a simple small low anal fistula was there. That was easily managed, but the remaining part and his thigh also has been extended. The infection was extended towards the thigh and the whole buttock. It took around 1 year to complete. Now it is okay. The patient is happy. Next slide. IFTAC, interception of fistula tract and Shara Sutra. Here, interception means we are blocking the tract, or we are intercepting the course of the tract. Here you can see there are two external openings which are demonstrated. One is a little far away from the anal verge at 5 o'clock position, and the other is at about 8 o'clock position. Next slide. So that track, both the track has been demonstrated with a probe. So this both track has eventually, it meets at a point somewhere below the anus in the midline. So that area will be explored, and from that opening, so we will make an incision at the joining area of these two tracks. These two tracks on the from the 8 o'clock and 5 o'clock, these would meet at a point, and that point an incision will be made, a window will be created, and through that window we will put a Shara Sutra, and the remaining track will be ignored. And this would be managed for sometimes with the sometimes I used to fill with the Shara Jala, and that would be eventually healed. So we should it needs a little time, no need of much more time as in the conventional practice. In conventional practice, we take a lot of time. Next slide. IFTAC is in progress, and I am putting an incision below the anus where the two tracks join. Next slide. So after, now I have demonstrated the two external opening with the needle, and the Shara Sutra is applied, not through the tract, through the tract, but not through the external opening. Next slide. See, it has been completely healed. The tract is healed, and the remaining two external opening without any intervention with Shara Sutra, it has been completely healed. Interception of fistulous tract. Interception. Interception means we are intercepting the pathway of the tract. Interception of the pathway of the tract, or the course of the tract, that is being intercepted by means of an incision or by means of a window. So through that window, we are putting the Shara Sutra towards the internal opening, and we are totally ignoring the external opening. But in all ways, it may not be successful. Sometimes there are chances of developing recurrence. The recurrence are due to many reasons. One is immunosuppressant problems, issues, or with chronic diabetes, or sometimes we will fail to find out the meeting point. If we fail to find out the meeting point of these two tracks, Or if we fail to trace the track in the course, there are chances of developing recurrence. Here it was a success. Interception of fistulous tract and application of Shire Sutra, that is SIP tag. It has been developed from a concept in the British Medical Journal some 25 years back. And that concept has been developed with the Shire Sutra by Dr. Manoranjan Sahu of the Banaras Hindu University. Now it is widely practicing, but if it is a success, then it's a great thing. Otherwise, again, the same procedure has to be followed. Mr. A from Varkala, ischiorectal transsphincteric horseshoe fistula. You see the word ischiorectal, it was ischiorectal, it was transsphincteric. Transsphincter means it is crossed the sphincter muscles. Horseshoe fistula. It's a cord fistula with a sternum opening at 4 and 8 o'clock position. It's 4 o'clock and 8 o'clock position, and both are traversing anteriorly, crossing levator muscle, levator ana muscle. So hence a complex supra-levator fistula. It is highly complex fistula. In modern surgery, there is no scope at all. Next slide. So this was the report of that fellow, that patient, from nucleic scans, and you can see the impression bilateral suprasphincteric fistulous tract with a common internal opening at the anorectal junction with an associated posterior levator ana abscess as described. Small pre-sacral fluid collections. This is the MRI report of this Varkala patient. Next slide, sir. Thank you. Thank you for the patient hearing right from 7:34. It is 9 p.m. More than a 1.5 hour is over.
Thank you so much, sir. Years of your admirable experience reflected throughout your presentation. Amidst all the busy schedule, the effort you took to put forward this session is much more admirable. Quoting the best references and epidiagrammatic representations shows the
ഇവളെ ഇവക്ക്
both as well as your cause, as well as your career, Shalya Tantra. Assuming that my episode wouldn't be enough, now let me invite our dearest Vice Principal, sir, the backbone of our institution, the one who had been there as the best guide throughout the organization of Yogya 2K23, Dr. K.V. Pradeep, sir, HOD, Department of Kaya Chikitsa, for the Thanksgiving speech.
Namaste, sir. Namaste, sir.
Namaste, 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 namaste.
It is an honor to have the opportunity to express my sincere thanks to our dearest Raghunath sir. I am grateful to the esteemed delegates of the webinar for their presence and effort in making this event a success. I would like to highlight that sir is the most apt person for this class as he is well experienced and through his immense knowledge. He has covered the important areas within a short time. Sir has treated different types of cases like fistula, piles, fissure, anorectal abscess, pylonidal sinus, etc. Sir is not only treat this, but also he is well experienced in orthopedic as well. Sir has discussed here the Nidhana, Pururuva, Samprapti, and different type of treatment methods, including oral medications, surgical and parasurgical methods, very well. I hope that each of you can become a great physician by incorporating this knowledge in your practice life. Last but not least, I would like to thank our dearest house surgeons of Sniasr for their hard work in making today's webinar a great success. Once again, I express my sincere gratitude to Raghunath sir, sharing valuable knowledge for us by spending this precious time. Thank you, sir. Thank you very much.
Thank you, Dr. Pradeep, for your kind words.
Thank you, sir. Dear delegates, you may now ask questions or doubts regarding the session. This webinar series have been organized in the hope of spreading knowledge. I request all of you to utilize the opportunity. So there is a question. In which case we need to do sphincterectomy in fissure in ano? Please elaborate some more about the procedure.
If there is too much spasm, when we fail to manage the spasm and pain with our normal procedure like dilatation, etc., that time we need to do lateral sphincterotomy. Any more questions?
Sir, I have one question.
Welcome.
Uh, in the perianal hematoma, apart from Gelugavjarna and internal medications, is there any other treatment methods that we can adopt for this condition?
There are two options. One is depends upon the size. We can incise and remove the clot in the pipes, or else we can remove as such. The whole mass can be excised. Two way of application, but that again creates a lot of infection because since the zone is highly a zone of E. coli, and it is better to apply this Gelugavajana. And last day also we have a case with severe pain. It came from Karnagapalli, and we managed with, I think, even after 10-15 minutes, the patient completely lived. And the only question is that there would be a stump that would be left in this area, and if the patient is, if at all any problem, that can be excised later.
Thank you so much, sir.
Thank you.
So we extend our sincere gratitude to all the delegates who joined with us today. We expect your support in the upcoming sessions also. Information regarding next session will be intimated accordingly. Once again, thank you so much, Dr. Raghunathan Nair, sir, for your wonderful.
Thank you, Dr. Likhita. And thank you, the House Students Association, for your great effort to manage and these kinds of webinar. And our college was, after COVID, we are lacking these kinds of events, and let it be an opening of these kinds of highly academic and informative sessions. Thank you so much.